Investigations in Cushing syndrome has two important targets. First target is to confirm the diagnosis, and second target is to find out the cause of Cushing syndrome. When patient presents with the multiple clinical features like centripetal obesity, purple stria, hypertension, proximal myopathy, that is patient cannot stand from the sitting position or cannot climb up the stairs, then Cushing syndrome should be suspected. First thing to do is to exclude the exogenous glucocorticoid exposure. Exogenous glucocorticoid exposure or glucocorticoid therapy is the most common cause of Cushing syndrome. It can be excluded by careful drug history. So when it is not the cause for Cushing syndrome, then one of the three tests should be performed. The important test is Dexamethasone suppression test. It is of two types. One is overnight dexamethasone suppression test, in which 1 milligram of dexamethasone is given at 11 pm and serum cortisol is measured at 9 am the following day. In low dose dexamethasone suppression test, 0.5 mg, that is half dose, 0.5 milligram of dexamethasone is given 4 times a day for 2 days, and then serum cortisol is measured. In normal individuals, when dexamethasone is given from outside, it suppresses ACTH. When ACTH is depressed, it cannot stimulate adrenal gland to produce cortisol. That's why serum cortisol will be decreased, that is will be less than 50 nanomole per liter. But in hypercortisolism or in Cushing syndrome, even after giving dexamethasone from outside, serum cortisol will still be greater than 50 nanomole per liter. So this is abnormal result. Next test is 24-hour urinary free cortisol. When it is elevated above the reference range, then again it is abnormal result. Next test is late night salivary cortisol. Cortisol has circadian rhythm, that it shows diurnal variation. It slowly rises in the morning, it peaks at about 8 am. It slowly decreases, and then at midnight it has the lowest physiological secretion. But when late night salivary cortisol is high, that is above the reference range, then it is again abnormal result. So among these three tests, when we do one test and if it comes normal, then Cushing syndrome is unlikely. But if we do one of these three tests and that test comes abnormal, then we have to perform other tests too. For example, if we do dexamethasone suppression test, it comes positive, then other tests should also be performed, that is 24-hour urinary free cortisol or late night salivary cortisol. If two of these three tests come abnormal, then Cushing syndrome is confirmed. But when all the tests are normal on repeat testing, then Cushing syndrome is unlikely. And next is, if one test is positive and the next test is negative, then additional evaluation should be performed after certain interval. But when in the beginning, when we do one test among these three tests and it comes normal, then Cushing syndrome is unlikely. So now we have confirmed the diagnosis of Cushing syndrome. Now next target is to find out the cause of Cushing syndrome. So after confirmation of Cushing syndrome, the important investigation is plasma ACTH. We know that in ACTH independent Cushing syndrome, plasma ACTH is less and cortisol is high, and in ACTH dependent Cushing syndrome, both ACTH and cortisol are high. So when plasma ACTH is undetectable or is less than 1.1 picomole per liter, then it is ACTH independent Cushing syndrome, that is problem is in the adrenal glands. That's why adrenal imaging with computed tomography is done. If CT, that is computed tomography, shows adrenal lesion, then it can be adenoma, carcinoma or ACTH independent macronodular adrenal hyperplasia. But if there is no adrenal mass or no lesion visible on CT, then it can be primary pigmented nodular adrenal disease or exogenous glucocorticoid therapy. But if when measuring plasma ACTH it is high or it is normal, then it is ACTH dependent Cushing syndrome. So problem is either pituitary tumors or ectopic tumors that are secreting high amount of ACTH. So now our target is to differentiate pituitary tumors and ectopic tumors. So one of the difference between them is pituitary tumors, they show some amount of normal regulation. That is, when dexamethasone is given from outside, it suppresses ACTH. ACTH will decrease. And when corticotropin releasing hormone is given from outside, then it increases the amount of ACTH. So pituitary tumors, they retain some normal regulation. But ectopic tumors, they do not show normal regulation. That is, when corticotropin releasing hormone is given, ACTH will not rise. And when dexamethasone is given, it will not be able to suppress ACTH. So to differentiate these two types of tumors, first investigation required is pituitary MRI. If MRI shows adenoma of greater than 6 mm, then next test should be performed, that is corticotropin releasing hormone test. When 100 mg of human corticotropin releasing hormone is given intravenous, if there is greater than 20% rise in cortisol and 50% rise in ACTH, then it shows the likelihood of pituitary tumors because it is showing normal regulation. And next is, if it is present, if there is positive CRS test, then next test to be done is high dose dexamethasone suppression test. Low dose dexamethasone suppression test, it cannot suppress ACTH because pituitary tumors, they are secreting excess amount of ACTH. But if they are given in high dose, that is, in low dose we gave 0.5 mg, but in high dose dexamethasone suppression test 2 mg dexamethasone is given 4 times daily for 2 days. So if it shows greater than 50% suppression in serum cortisol, then it is Cushing disease. But if MRI shows adenoma less than 6 mm, then bilateral inferior petrosal sinus sampling should be taken. If MRI shows greater than 6 mm adenoma but CRS test comes negative, then again this should be performed. If both MRI shows adenoma greater than 6 mm, there is positive CRS test but high dose dexamethasone suppression test is negative, then again this test should be performed. So what is this test? So in this test, sample of blood is taken from right and left inferior petrosal sinus and ACTH is measured. This is called central ACTH. And peripheral vein blood also is collected from peripheral vein, and ACTH is measured in this blood. This is called peripheral ACTH. So when the ratio of central to peripheral ACTH is greater than 2 at baseline and greater than 3 after giving corticotropin releasing hormone, then it is Cushing's disease. But if the ratio is less than 2 and less than 3, then it is case of ectopic ACTH. And to find out the cause of ectopic ACTH, CT or MRI of thorax and abdomen should be done to find out the lung tumors or pancreatic carcinoma or pheochromocytoma.